For you guys out there in the audience, appreciate you joining us tonight to talk about practical use of 2.5% iPAAG Orthopedic from an equine surgeon's perspective. We'll get started. I'll give you another minute for all of the folks out there to log on. Just to kind of introduce you to some of us, my name is JD Conway. I'm the Director of Veterinary Services here in the U.S. We also have Jason Lowe, who's our Chief Veterinary Officer at Contura, and who will be moderating the session today. The panelists will include Dr. Lisa Fortier, boarded surgeon. They're all boarded surgeons tonight. Dr. Fortier comes to us from AVMA, Editor-in-Chief of JAVMA, AJVR, also from Cornell. Dr. Kyla Ortved, University of Pennsylvania, professor, surgeon, and diplomat of the ACVSMR, has graciously presented some cases that we'll discuss as well throughout the webinar. And last but certainly not least is Dr. Wayne McIlwraith, former professor of mine, boarded surgeon, PhD diplomat, ACVSMR. I think most of you guys know him out there, and his research when it comes to osteoarthritis is pretty legendary. So thank you guys for being here, to the panelists, and thanks Jason for doing the moderating tonight. I do want to go to a disclosure slide just to make sure that the panelists, if they have any disclosures, they're welcome to talk about those now. We'll start with Lisa. Do you have anything?
I don't have anything relative to Contura or Orthopedic.
And Kyla?
You're muted.
Thank you. I sit on the scientific advisory board for Contura, who makes Orthopedic, but nothing else to disclose.
And I'm also on the advisory board for Contura Vet.
Thank you guys for that. And without further ado, I'll turn it over to Jason, who will get into some of the questions, and I'll stop sharing briefly until we start to go through some cases. So Jason, it's all yours.
Okay, great. Thanks a lot, JD, and welcome everybody. And yeah, reiterate the thanks to our panelists tonight. I guess I was just sort of going to start with you, Wayne. 2.5 iPAAG, the Arthromed products come onto the market. We've got some great new data come out of the osteochondral fragment model, understanding its mechanism of sort of therapeutic approach to treating the synovium. And I was just interested in your thoughts, sort of how our understanding of the role of synovitis and the synovial membrane has changed over the years in relation to OA and joint disease.
Well, it's obviously a great question. And I go back a long way, being the old person here, but when I went and started my residency at Purdue, I was given a model of synovitis to look at. And of course, at that time, we were putting corticosteroids into joints. I think all vets who were working on athletic horses knew about inflammation in the joint with osteoarthritis. So it was kind of ironic when I got this model that the human literature was absolutely osteoarthritis is not an inflammatory disease. You had these two portions. One was that you had the two positions. There was osteoarthritis, which was a non-inflammatory disease. It was degenerative, and then you had the other one, inflammatory, but that just included the so-called immune-mediated diseases like rheumatoid arthritis. And so we subsequently showed that without trauma or without instability, we could produce OA just by purely inducing inflammation. So that was the start. So really, we were involved in the veterinary sphere or the equine sphere. That was the first demonstration of the principal role of inflammation in OA. And now, probably starting 10 years ago for sure, there was a great paper published with some of the luminaries of human OA where they did have an ice graph there and it was talking about inflammation, a big curve up where the inflammation occurred. So that's sort of the evolution. Now, what's happened is that it's almost concomitant with the development of Arthramid and Arthrosamid that I started looking into the literature. I sort of had a long history in synovitis, and I maintained my interest in it. And then when Arthramid came along and I started looking at the literature again, it was voluminous. And it was like there's at least 40 publications in the last 5 years on synovitis in human osteoarthritis. So it's almost like the perfect storm, Jason, that we've gone from evolving from a non-inflammatory disease to an inflammatory disease in human, or at least inflammation being a huge primary part of the process, and inflammation of the synovial membrane. We have continued on, and of course, we're really interested in it because we have a number of options for osteoarthritis or treating synovitis, but we're really treating synovitis. And sort of most of the publications in the horse have usually used the term osteoarthritis, and that's okay because back when we decided to put a classification on equine osteoarthritis, we had 5 stages, and stage 1, was inflammation, synovitis, and no observable morphologic change to the articular cartilage. And as you go from 1 to 5, you reduce your amount of inflammation, or the acuteness of it becomes more chronic, and you start seeing that progressive loss of articular cartilage, or progressive lesions in articular cartilage, superficial fibrillation, chondromalacia, and then all the way down to loss of the full thickness of the articular cartilage. So synovitis is critical to the role. I think we as veterinarians have always treated it, but it's certainly more recent as far as the human sphere goes.
Yeah, it's even quite interesting, isn't it, looking at the literature even a few years ago with the likes of the Nobel Nobel Prize going to this discovery of piezoreceptors and that sort of relationship of mechanoreceptors and nociceptors, and understanding that sort of launch pad, if you like, for the disease complexes.
Well, and the cellular changes, the importance of the macrophage, and and that work's getting done in the horse too.
Yeah, no, thanks for that. It's I guess I'll throw the next question then at Lisa, sort of following on from that. Our understanding now of the role of the synovium and synovitis that Wayne's just talked to. How do you think that sort of what are the practical implications for veterinarians around how we should be looking at managing joints as a result of that?
Yeah, I think they to avoid really thinking of it as just pure inflammation, because I think if you really distill that down, a lot of us think, oh, inflammation is bad, red, hot, swollen joints, and quell that as quickly as possible. And of course, that could be done with corticosteroids, but understanding that the whole inflammatory process, from neutrophils to T cells, macrophage, monocyte, the whole spectrum that we were all taught about wound healing is important, even in a joint, whether it's a joint wound or just synovitis. So really getting through that process is what we need to do, like squish it down a little bit more, but that whole cascade is really important. We want to get through there quickly, but if we stop it at one stage, or if it stalls out at one stage, that's where we end up with fibrosis and continuing disease. So again, trying to manage synovitis to get us through that inflammatory process. So get through the inflammatory neutrophils as quickly as possible, get onto the monocytes and macrophages that we were talking about, get into the M2 phase, and get on with restoring joint homeostasis.
Yeah. So you're sort of, potentiating that process or managing them through that process, and then I guess starting as early as possible in that sort of intervention. Is that sort of what you're saying?
Yeah, I think that's critical in everything, right? Treat early, don't wait until it's too late.
Yeah. Instead of putting out fires. Oh, that's really cool. Kyla, sort of, have you changed your messaging around with clients on that basis of this idea of, I guess, early intervention? And we've always talked about acute and chronic disease, and I've always sort of struggled with what's the difference, because lame is lame when the horse is presented to you on the day. But
Yeah.
have you sort of changed your discussions with clients based on this sort of growth in our knowledge, or?
Yeah, and I think, I mean, both Wayne and Lisa just said it about our ability to intervene early, which is something that I think in the horse world we actually are really good at and we do quite a bit of compared to the human world, where it's, you'll have a bad knee that'll go for ages and ages before you're even eligible for an injection. So I think our ability to jump in and do something early is pretty important, because we know that this whole disease process is a process that once it gets past a certain stage, we have very limited ability to change the outcome in. So with the synovium, like most of these horses that we see often have an inciting injury or an accumulation of trauma to the joint over time, and the synovium is inflamed. And I think if we can treat that inflammation and sort of either quell it or stop it, then we can protect the cartilage a little bit better. And cartilage, as we all know, and Wayne and Lisa know very well from all of their work, it does not heal very well at all. It's clearly everyone's favorite tissue, but it is a really poor healer. So if we can protect it, I think that can be really important. And it, the like Wayne was saying, Arthromed has come around at a time, and especially now that we understand its mechanism of action a lot better, it's come around at a time where we can use this treatment to actually target the synovium, change the physiology of it, change the properties of it, and then use that to presumably alter the joint environment, and like Lisa said, make it a more homeostatic, protective environment moving forward. So in terms of messaging, yeah, I mean, that message has absolutely changed. And I would say, I would be interested to hear what Wayne and Lisa would say on this, but when I first started using Arthromed, I definitely used it more in sort of end stage joints. It would be, when I thought of it more as a lubricant, like put it in this really, end stage joint, it'll help the horse feel more comfortable, it'll help protect the joint surface. And now that we understand what it does so much better, it's a medication that I recommend very, very early on.
Yeah, I agree with that, Kyla. I think the other really cool thing that you said was actually as equine vets, we're pretty dang good at getting in there early.
Yeah.
And I think our companion animal colleagues are starting to do that too. So they don't wait until the fat Labrador has such a bad elbow they can't walk anymore.
Yeah, I agree.
Yeah,
I think
that's a
that's
great
really an
point.
important aspect. And we were the same way. Like I was involved in looking at Arthromed, or at least them, that was when usually people would come. They didn't want to pay much for research, but this is prior to Contura Vet obtaining the company. But it was exactly as you said, Carla, rightly or wrongly. I had a box of Arthromed, and encouraged the clinicians to use it on end-stage joints, or not so much end-stage joints, but chronic joints. And our results were mediocre. And it was just that was the way it was presented at that time. But it's quite an amazing change, really, that it's become principally oriented around the synovial membrane. And
So do you want to
that's changed our mentality as how soon we might use it.
do you want to talk to that a little bit, Wayne, just on that mechanism of action that Kyla brought up? And obviously, I think the insights that we've gained from it going through the osteochondral fragment model with your team at CSU and the Medicine Institute. And I guess if I get you to talk specifically to Marcus Wimmer's work around the sort of
Yeah.
softening and elasticity of the membrane, and then I might take that to Lisa around that sort of cellular macrophage downstream effect.
Yeah, sounds good. So for those of you who are not aware, that we've just completed a study in the CSU chip fragment model, which is pretty commonly known, has been used a lot to validate multiple medications or treatments. It's just been tested. We've finished the study. There's a report being given to Contura, and we're preparing manuscripts, but there's a couple of, so we've got a response to it in the model, but as Jason asked, there's two important things that we did that answer some of the critical questions. And the first one is that we collaborated with Marcus Wimmer, and we took samples of synovial membrane, collected them using actually one of those Arthrex oats core bores. And so he got, actually, I'm just going to swing to that. I've got my cheat notes here. Obviously, I don't remember all of this, but hang on a minute. And the specifics were basically Marcus is at Rush University, and he's and so we looked at histology and we looked at nerve endings too, and we'll come back to the nerve ending thing separately. I think Jason would be best. But anyway, we collected these 32 synovial membrane samples. So each joint, there were 16 joints and treated, and 16 joint controls. They were injected with saline. And we sent them to Dr. Wimmer to test shear stiffness of the equine synovial membrane. And so each joint served as its own control. So in other words, when we broke the code after Dr. Wimmer had made his measurements, we just compared the treated joint to the saline treated, the placebo joint. The stiffness of the synovial membrane significantly increased in OA saline treated joints. And I don't think I want to bore you with the PA, but it was a significant level of stiffness that increased in the saline treated joints. So that's in the control joints, compared to their respective sham controls. So that was comparing saline joints to joints. We always have a sham control in these studies as well, where they're not treated with anything. We do scope them to make sure they've got normal joints at the time we induce the fragments. In contrast, in the treated joints exhibited similar stiffness to their respective sham controls, indicating, the stiffness of the synovial membrane significantly increased in the OA saline treated samples, and that was significant compared to their respective sham controls. And then the delightful part of the results were that the shear forces were significantly decreased and did not differ from the sham controls in the joints that were treated with arthramid. The joints that had a fragment had osteoarthritis and were treated with arthramid. So that sort of supported the hypothesis that a lot of people, including me initially, had trouble getting their head around putting an inert product into the joint that then goes into the subintima and takes up residence there. And but we've clearly showed in the chip fragment model that we do get stiffness in the synovial membrane, and we can treat it successfully with arthroid.
And I think it's so well recognized that in human medicine, isn't it, where they talk a lot more about the fibrosis and things. So like you say, it's lovely to have that primary mechanism of action clearly defined. Just a reminder to our audience, if anyone has any questions, you can use the Q&A, and JD will come back to some of those for us.
One other comment on that study would be, now I'm going back to the old days, but at the time I started reading the OA literature, and this is in the 74, 76 period, they recognized that stiffness of the joint capsule as a whole, there were quite a lot of biomechanical studies, was a promoter of osteoarthritis. And so if you, in other words, it was sort of like we always knew, or it was always stated, that synovial membrane and fibrous joint capsule stiffness was a big factor in the pathogenesis, not just in the signs like a horse with reduced flexion. And yet we sort of, I don't know, I kind of forgot about it before we started getting back to talking about Arthrimid.
Have you got any comments to that, Lisa? And then I'd also sort of ask around, the paper that was published last year around this sort of macrophage-driven response to the gel, and you sort of mentioned before this M1, M2 macrophage, good inflammation versus bad inflammation. And again, I know that some of the other data that Wayne's alluding to was presented at ICRS, Lynn Pesanite's work specifically around this sort of downstream effects, that once we've restored that synovial softness, we seem to get the joint to restore to more homeostatic behaviors biologically. Have you got sort of thoughts on that? Or
Yeah, I find it curious that both of you guys are using the word restore, and I would use the word maintain. I don't think you got to joint stiffness and then returned it to a supple joint. I think it maintained a supple joint. And you and I have talked about in this same chip model, which is fascinating to me, there's less sclerosis in the radiocarpal bone in the treated than either in the iPAAG treated compared to saline or sham. And I think that's fascinating. So it's not that it stops it from ever forming.
Yeah.
Right, you're maintaining joint homeostasis. You're never letting it stall out. And I think that's also Lynn Pesanite's work is just drop mic, walk away sort of stuff. It's just out of this world fascinating. She does one of those omics sort of things on transcriptome and what all these different and on all the different synovial membranes. And it's important why we keep focusing on the synovial membrane, because that's where all those inflammatory cells come from the synovial membrane into the synovial fluid. And that's what has the effects on cartilage and then the subchondral bone and all those other things. So that's why, for people that don't live and breathe the synovial membrane, which means you have a life. But that's why we keep focusing on the synovial.
You've become quite a bit more pedantic since you've been a journal editor, because obviously we showed in the research project that we were producing disease, and as you acknowledged, we got decreased sclerosis in the radiocarpal bones. But that's just a stage of disease, which we're just modeling. So your point's well taken. It is preventing, because obviously in the chip fragment model, we start off with normal joints.
Right.
But on the other hand, you don't know, I don't know, maybe you do, when in the process of, take for instance, the thoroughbred racehorses that, Jason has done a lot of work in and reported on, they're pretty early synovitis. So do they have at that stage, do they have any significant stiffness? So the thing is, we don't know when the stiffness is there, but it just, to make the point, you need to be on top of it sooner the better, sooner than rather later.
Yeah.
Yeah. It's interesting that though, isn't it? Because like clinically, when I get a reaction to passive flexion, get that sort of joint stiffness and pain, those to me in a racehorse were really good candidates. I knew that they're going to respond. And now that we understand a lot more about what this molecule is doing, it's quite nice to sort of understand why that was. Going back to the macrophages, Lisa, again, I guess just to address the issue, or the people have asked questions, this is a foreign body response and it's driving macrophages into the joint, and that must be really bad. How would you sort of answer that?
Yeah, it's a really great question. There's something in the chat about a granulomatous reaction too. And I think for all of us that look at synovial membrane, whether you're doing a cartilage repair study or whatever it is, when we first saw the polyacrylamide incorporated into the synovial membrane, none of us really loved it, because as you just said, we didn't understand the mechanism of action, and we just saw cells, and you think cellular infiltrate, bad. And we just didn't know. And our thinking has evolved to a neutrophilic response would be bad. depends on the type of lymphocyte, and it depends on the type of macrophage. And we know from Lynn Pesanite's work that we had started to discuss that these are tending towards the M2, the reparative type of macrophages. So it's certainly not a foreign body response. There aren't any multinucleated giant cells in there. And our even in mine and Kyla's and Allen's and Wayne's and Goodrich's and a lot of our work, our understanding of the synovial membrane has evolved and what those cells are, and it has really changed, and all cells aren't bad, and the M2 macrophages are good.
Thank you. That's really good. JD, have we got any questions you wanted to address now?
Yeah, so we've got a few that are popping up, and I'm sure more will as we progress through the discussion here. One of the first ones was really, and it goes back to, I think maybe Kyla or Wayne we're talking about just treating horses in various stages of disease. The question is really related to Orthved's therapeutic efficacy in horses with end-stage OA versus early-stage disease processes. Does the panel have any thoughts on whether combined therapy with steroids could benefit the end-stage OA patient? And then there's another follow-up question later, but I'll let the panel answer.
Yeah, I can start with that, JD. So when I mentioned earlier that when I first started using this product, it was more an end stage, and I do think it helps to some degree, but we're not at a point that we are gonna significantly change the process of the disease or reverse any of the serious effects that have occurred in those joints. So I think, you know, if you say in these end stage joints, like the horse got a little bit better, a little bit more comfortable, but really didn't improve significantly, I think because we're taking something that's awful and making it slightly less awful. And so with treatment of joints before they get to that stage, so the earlier joint treatment, which I think we've all said we're in the equine world, we've always sort of focused on, I think we've gotten better at it. And I'll just add as well, I think in the equine world, with our use of imaging and a lot of the advanced imaging, we're recognizing these issues in joints much, much earlier. So that gives us the opportunity to intervene at that stage. And like I said before, make a significant impact on the long-term health of the joint. So I would always rather treat an early stage joint every day, no matter what, because it's a lot easier of a job to do, and the outcome can be a lot better all around. I will say, if the question about the combination of steroids, I've done that quite a lot, and I do, if the joint's really inflamed or the horse is very painful, I've combined corticosteroids and Orthmed at the same time, or in some horses stage them, and I think it is. Obviously, I don't have any evidence at this point myself, but and I know there is some published literature, but I think can be a very effective way to treat horses, especially when they're in that really inflamed state.
Yeah, I think so too, Kyla. I often will start with some type of biologic, maybe a steroid, but if they're really inflamed, I don't know that this is just the way I try to set up Orthmed for success. And so put in a biologics to start and then come back 2, 3, 4 weeks later with Orthmed. And sometimes it's just too much volume at the same time as well if you're going to try to do polypharmacy.
Just to add to that, you know, corticosteroids are still the most potent anti-inflammatory we have and the most potent reducer of lameness that we have. And so if you're at a late stage joint and you're using, you know, you've shown with the study that was done by Dr. Whitaker, you know, you can use corticosteroids, at least triamcinolone acetonide, in combination with Orthmed quite well. But it's really important to realize, if you're trying to give that horse comfort, and that's what the owner wants as well, no, corticosteroids are still going to be an important part of your armamentarium. one of the things that get confusing to clients, though, is the continued bashing of corticosteroids in human, but they still use them a lot, but they don't know as much as us about dose and using it. They use extremely high doses. They get terrible complications. Well, I shouldn't use the word terrible, but they get many complications. And we had an MD who was a very prominent MD orthopedic surgeon as the Jacques lecturer to VOS this is probably 10 plus years ago. And he was using heavy doses of depomedrol in high school athletes. And so I talked to him about how we've shown that depomedrol is the one that's really harmful to articular cartilage, at least in high motion joints. And it was sort of like he was surprised. I don't know if he changed his practice or not, but we've got to be careful with the combination. But, relief to a horse when that client wants to keep the horse around and has the humane limitations. I'm not talking about keeping it at athletic activity. It still gives them a lot of comfort, I think.
Especially to be a little more considered in the warm blood population and the ponies, right? The more and more we know about metabolic syndrome, it's not necessarily the super obese, but I just get more nervous about using it in slightly metabolic looking horses.
And that's a good point. That's fair. And
Which so many of them are now.
Yeah.
Yeah, it's a good point, which is where this product, Arthrimid's just great, isn't it? Because it's not having that risk of the same side effects, and then in combination with biologics, you're getting the best opportunity. So,
but judicious use in low dose can help. Back to the original question.
Yeah, and I think some of the original, again, when we didn't know as much about the molecule, we were sort of talked about this integration process, and did corticosteroids suppress that because they'd suppress the fibroblast migration. But we know now that that's not how the molecule passes into the subintima. It's purely filtrated through the intima into the subintima, just through that natural clearance mechanism. So I think what it says to me is there's no contraindication not to combine with corticosteroids if you think that the case warrants it. And as to your point, Kyla, I think those sort of angry, inflamed joints, you just want to settle them down quickly.
Yeah,
And
absolutely.
yeah, to add to that further, there is some evidence coming out of human medicine with the arthrosamid equivalent of arthrimid showing that the non-responder group tend to have higher IL-6 levels. And so again, it probably makes sense to knock that down with your corticosteroids and move them into a responder group. So, but again, they're treating much sort of more chronic end-stage disease, which is perhaps similar in the canine, but it comes back to where we started is let's treat early, and with a product like this we can. JD, have you got any more questions you want to answer now? I wonder if this is a good time for
I think
Kyla.
this one kind of gets to some things that some of the folks might want to know, and it goes back to the chip model. I think you and Wayne can answer. Said, could you help clarify the findings of the treated joints in the chip model? So I think it's just kind of going back and looking at the horses that were treated with either saline or they were treated with Arthrimid, maybe clarifying how much they got, in each limb. And I don't know that we have to go into it too much in detail, but I think
I'll keep it pretty loose. Because we haven't put a manuscript in yet, and sometimes you live in fear of prior publication rules. Not every editor is as smart as Lisa Fortier, I can tell you that. And so, but no, we showed, well, one's already been alluded to because Lisa's familiar with the work. We did not show significant difference in lameness, but we seldom do, because you've got limited grades. These horses are put on a treadmill. Put it this way, there's always an improvement in lameness in the treated group in most good products, and there was with Arthromed. It's just statistical significance. We showed an improvement in saffron and O staining in the articular cartilage, which, as most of you probably know, is a marker of proteoglycan content, which is the first thing that goes and the important part that goes in the articular cartilage in the process. We showed reduction in sclerosis of the radial carpal bone. That was interesting. We don't see that very often in other studies we've done. And you know, above all, we had no negative side effects with any of the horses, any reactions that weren't just in the normal grounds of doing an injection.
Sorry, Wayne, did you say no change in there was no difference in synovial membrane between any of the three groups, right?
No, correct. Well, what there was is there was a clear increase in the treated horses as far as mononuclear cell infiltration. And that was an important parameter in the histology of the synovial membrane.
But again, within normal limits, right? My understanding, not a significant difference to the sham or saline treatment.
Yeah, like it wasn't overwhelming difference.
Yeah.
But I think, you know, we can explain that. We haven't got down to the really hardcore discussion, you know, of interpretation. But my feeling is that, you know, we're at an early stage. This is an early stage model. It's a 10-week model. But it's certainly a model of osteoarthritis. You know, you get all the cardinal symptoms.
I think it's at least his earlier point, it's that lack of progression of the disease that you saw in the saline treated group through to cartilage erosion and degradation. It just, and the sclerosis, it just didn't happen in the iPAAG treated.
But I think the radial carpal bone sclerosis, that was significantly reduced with treatment, which when you think of a 12-week course from the time you initiate the model, 10-week course, it's a 10-week time period. So you've already got change radiographically. And in some other studies, you know, horses vary. Like we had very, very advanced, we had changes radiographically in the controls and the treated. Radial carpal bone sclerosis was the only one that was significantly different. But, you know, you always put yourself at a 5% level, which means, you know, you'd only be wrong in 1 out of 20 cases. Well, so that's a risk, but it's the way you do your statistics. But like, for instance, another study we did on a different product, we had a lot more severe radiographic change in the controls, and therefore we showed a more dramatic improvement in the treated. So the model does vary. That's why we've always got to have a control group. We've always got to have a sham group because these horses vary a lot.
Did that sort of answer the question, JD?
Yeah, no, I think it does. And I think a lot of these other questions might be answered a little bit too if we get into the cases, because it's talking about what we treated, where we treated hawks or, you know, a fetlock or whatnot, and volumes of use and things. So
if
it
you want
might
to
be
set Kyla up with one of those, and I think while you're doing that, I'll just make the comment that because Erin Contino and Katie Seabow have done posters and presentations at ICRS and ACVS on the sort of key findings out of that model, which are available. So if people want to see that, they're more than welcome to reach out or search those two Congress websites.
While we're keying it up, not to do your job, Jason, but I think one thing we should say is that the old, well, I shouldn't say old, but the often repeated question of neurotoxicity with Arthromed, we looked at that really closely and with various markers and on histology with immunohistochemistry. And there was no change in the treated horses compared to the non-treated. And so I think we can fairly well put that away. And then at the same time, there was an in vitro study done in, which I won't take your time with because get into cases, but also that mimicked the same results. So I think we've fairly well dealt with this neurotoxicity or loss of neurologic function issue.
Yeah, thanks for clearing that up, Wayne. It's well put to bed that now, and when you actually understand the molecule and what it is, how it's produced, how it behaves, it's not neurotoxic, and we've proven, yeah, and that's been shown nicely now in vitro and in vivo studies and confirmed probably over 20 years, to be fair. So that I appreciate that. So Kyla, yeah, I'll hand over to
Yeah,
you.
can I just add one thing to that? Because I think, like, again, this is something that comes up a lot, and it is a commonly asked question. And I think one thing that's important is the sort of the history of why people assumed it was neurotoxic, and I think it's important to like point out the different chemistry of so acrylamide monomer by itself has neurotoxic properties. A polyacrylamide has no neurotoxic properties. And so these products that we're using are polyacrylamides and are not neurotoxic because of their chemistry. So I think it's like that is like such an important part of understanding where these sort of notions came from and why they are so different.
Yeah, that's right. And they can't, the polyacrylamide cannot break down to an acrylamide. It's
Yeah.
just chemically impossible
Yeah,
unless you heat it to about 800 degrees in high centrifuge forces.
And you're going to have more problems with the horse if it's 800 degrees
at
than the
physiological
polyacrylamide.
levels.
So.
Well, no, and I think it's really important, and glad you brought it up because I only learned about a polyacrylamide monomer being toxic one day when I was looking at the ACBSMR listserv because there was a big argument going on about basically it was pretty much the consensus was from a majority of two that it was bad. And so I just didn't have time to get into an email fight, but I think that's pretty futile and I haven't got the time for it. But the important thing is that it's amazing how people dig up this other information because I didn't know it. Did you carry that around in your head, Kyla, from chemistry or?
No, God, no. I mean, I probably should have known it when I was working with a lot of acrylamide. No, but it's something that I couldn't. I've heard of this, especially within the racing world, especially within the U.S. racing world. I've heard with so many people talk about it, and I didn't understand why or where that had come from. So I sort of went into a little dive into the literature about why that was
Yeah, good.
how that held true, why that was the thing that people had thought about.
Yeah. No, I appreciate you for bringing that up and explaining it fully. So yeah, I'll let you run through this case because, as JD sort of said, it's quite interesting and what comes out when you look at how you can successfully implement this.
And I mean, these are nothing special. And I was just highlighting a couple ways that I've used Arthrimid. Obviously, this is totally anecdotal. And we can't, I'm not going to claim this as evidence, but just more highlighting from my perspective how I've incorporated it into a sports medicine and surgical caseload. So this first horse is really just a sports medicine case. The next two are post-operative treatment, in case that's interesting. So this was just a 15-year-old Oldenburg gelding with a fairly chronic history of left hind lameness, about a year duration. The horse was meant to be a dressage horse, had performed at a high level of dressage previously, but the owner, obviously with the lameness, was having issues. Both stifles had been medicated with corticosteroids, and I should say both medial femorotibial joints have been medicated with corticosteroids historically, and that was with triamcinolone at the time. And the horse definitely improved, but that improvement, according to the owner, was quite transient, and had a recurrence of that left hind lameness. So when he came in to us for evaluation, he had a grade 3 to 5 left hind lameness that was mildly exacerbated on a circle to the left. The lameness was localized to the medial femorotibial joint. And then, Jason, if you go to the next slide, just on imaging, the imaging of his stifle. So on radiographs, you can clearly see that there's osteoarthritis of the medial femorotibial joint. We have significant osteophytosis in that joint, both on the medial tibial plateau and the medial condyle. And then ultrasonographically, Jason, if you go to the next one, on ultrasound, there was on the top left here, there was effusion of the medial femorotibial joint, and then the medial meniscus had a pretty reliably disrupted echogenic pattern to it. So we were concerned that this horse had medial meniscal injury as well as either primary, secondary osteoarthritis consistent with that. On the bottom panel, that is on the left, is that medial meniscus that you can see that has some irregularities to the echogenicity of it. And then to the right is the cranial meniscotibial ligament that looked mostly normal in our imaging. So this horse, I actually, because when you do surgery, obviously everything needs surgery. So I had recommended surgery for this horse and it wasn't an option. And so this was a horse that we said, okay, well, if surgery's not an option, we'll try Orthopedic on it. And so put it in the medial femorotibial joint, left hind, and the horse, within a couple of weeks, was back under saddle and was working as a dressage horse for the next 6 months and remained sound. So I think this was a case that I saw a while ago. I was pretty pessimistic based on the imaging, based on the medial meniscal imaging and the radiographic imaging, but I was really pleased with the outcome.
Kyla, what volume did you use and why?
Oh, it's a good question. So this was only 1 mil. I did not increase the dose in this horse. I used 1 mil in the medial femorotibial joint. I often choose the volume based on what the owner, so based on the size of the joint. So smaller joints, I think 1 mil is adequate. I have injected really small spaces. So if I've injected some navicular bursas, and those I'll split 1 mil. So it's only 0.5 mil just from a volume perspective, because I think those horses can get sore when they have a large volume in the navicular bursa. In the larger joints, I have injected more than, so 2 mils. And honestly, that a lot of that comes down to wanting to do it in the larger volume joints, because I think intuitively it makes sense, although we don't necessarily know that. But often it comes down to cost and what the owner is willing to spend on the injection of all the things we're doing.
Thank you.
Yeah, that's a really good comment. I mean, I sort of break it down because we had a lot of questions on dose, and I think again, looking at the work from Marcus Wimmer around the biomechanics, does it sort of, if we have a more fibrotic synovium, do we need to put more in to try and restore that, or is it the amount of downstream effect and sort of this macrophage infiltration? Are we trying to stimulate that more, and the more surface area of gel we put in, would we get a bigger response? But I sort of break it down into mild, moderate, severe, and I think in the severe disease you get as much in as your owner can afford to pay for. But like you say, dealing with racehorses, economics often isn't an issue, but we're treating very early in the disease, and
Absolutely.
I think 1 to 2 mil seems more than adequate in that early synovitis cases. So.
In this case, Kyla, sorry, go ahead, Wayne.
Yeah.
Oh, just one comment, Jason. Just recently, you told me about how with human, they were initially using 3 mils and went to 6 because they weren't that pleased with 3, went to 6, and had significantly better results. And we all know some people that have had 6 mils,
Yeah.
veterinarians who have gone over and got the treatment. So I think, but on the other hand, I think we'd also probably need to caution the fact that most of those cases being treated are more chronic osteoarthritic joints than our equine joints.
I was just
Yeah,
gonna
that's
ask a
right.
very similar question though, Wayne. So like, if Kyla's disease is contained to the medial fem-tib joint, right, if you ultrasound, I presume you ultrasound the lateral fem-tib and the femoropatellar,
Yeah,
and if they're
exactly.
kind of, and if they're kind of normal looking, you're basically treating the equivalent of a small human knee. I mean, I don't really know how to extrapolate that, but you're really, I think sometimes we think, ooh, you're doing the whole stifle, but maybe Kyla really is only treating the medial fem-tib joint. And I
Yeah.
don't know what that volume is.
Well, I think it's an interesting factor because, her radiograph showed she had the tibial osteophyte, but she had some change on the femur, which that's also a big deal breaker to me as far as I can handle a lot of, I've always thought I could handle a lot of proximal medial spurs on the tibia, but I don't want anything on the femur, or I don't want anything elsewhere. But it is really huge. Like, I think it's impressive that 1 mil response when you've got the meniscal pathology as well. But I think it goes to, why do horses with meniscal tears, a lot of them, why are they lame? Well, they got synovitis, haven't they? But it's a good question, Lisa. I think we haven't sorted out dose, and it's very, very hard to do a dose titration study, really.
What did the other two compartments look like, Kyla, on ultrasound?
Normal and ultrasound.
See, I put that in the category of, with both the others normal, Lisa, that, yeah, I think you can be pretty safe that you're treating the femorotibial joint.
Yeah,
You're not getting it into the femoropatellar joint,
yeah.
but you can never guarantee it. But, it's perhaps you're getting it into the femorotibial joint, and because of the localization that occurs quite quickly, we know that in the synovium, you're getting your therapeutic effect there.
I think it's an amazing to see 1 mil being effective in that severe
Oh, yeah.
pathology. But as to the human stuff, again, it's quite interesting because we're getting some longer term data come out. So actually, and overall they see around a 75–80% efficacy. But if you take out the over 70-year-old, that goes up to around 90%. And if you take out the over 60-year-old, it's going up to close to 100%. So again, makes me think, is it the chronicity of the disease or the competency of their immune system,
Yeah.
which is changing the response to the different.
That's a good point. They've got data like that. Yeah.
Yeah, just
Is it
started to see
published?
it.
Yeah.
No, not yet. It's just Martin Snow in the UK, so it's coming, but it's a real
That's
difficult one.
Yeah, no,
And
it's
that's when I talk to veterinarians, I just say, and what was the comment Bo Whitaker had, JD? It's about the disease
Pathology,
status
dose,
rather than
yeah,
the
dose
volume
based
of
on the
the.
pathology of the joint. Yeah, that's what Bo had stated, and he still finds that true. And I think if he goes, when he did his tendon sheath lesion creation and then injected it and saw actually histologically where the gel ended up, it kind of speaks to that a little bit more. Now that's unpublished work by him, but he's has a white paper out there on it, and it's pretty interesting. But
Yeah, I'd love to
Kyla's got
see
a
the
tendency.
scans in Kyla's case because I wonder what that meniscus looks like now. It's
Yeah.
really interesting. Hey, I'm just conscious of time. I guess the other, and it sort of segues on from that, and there's one of the questions in the chat group there, and I'll put it to all of the panelists because knowing what we know now about arthrimid, the gel, where it's working, these downstream effects, where does it sit, in your opinion, in the post-surgical case? Because I know, if you've gone in and done a fragment or, cleaned the joint out, diagnostic arthroscopy, whatever, where do you think this gel fits? Don't rush.
Well, I must confess, I didn't, I've sort of greatly slowed down my surgical practice. So, but I think intuitively, now that we know what Arthromed does, appropriate, but not immediately after surgery, because you got to get rid of the inflammation. And but I think that the effects it has on synovitis, it's certainly appropriate if you have some, if it's starting, if you've got a pristine joint, no. But if you've got a joint that's got some of that early change, you've got early fibrillation, it can't do any harm if the owner is willing to do that.
Yeah. Thank you, Kyla.
Yeah, I mean, I would say, and I saw this in the chat as well. So I never, rarely inject joints at the time of surgery because I feel like it's a little bit of a waste of the injection. You finish scoping a joint or a tendon sheath, and it, like, you pull the scope out and it just bleeds into the space. So to me, that's not, I feel like I'm not maximizing the use of the product no matter what it is. So I usually recommend injecting 2 weeks post-operatively when the joints settle down. We know the synovial fluid has improved. It's not fully back to normal, but it's made a significant shift in that direction. So I'll often have people treat at that time. And I think what Wayne has a good point too. Like, if it's a pristine joint, it's a small chip you're taking out. It's not really necessary to go back into the joint, but these other things. So I do a lot of digital flexor tendon sheaths and joints that are inflamed, or they're having some, surgery where it's going to be in a very inflammatory process. I like to use Arthromed, and I also use a lot of biologics post-operatively starting around 2 weeks.
Yeah, I totally agree. I never inject. It's always been intuitive that for the same reasons to inject at the time of surgery. You've got a lot of inflammation going on immediately after surgery. So, yeah.
Lisa?
I think the rare case where we're talking about the pristine joint are the rare thoroughbreds that have a small carpal chip fracture, dorsal medial P1, and the owner or the trainer bring them in straight away. The synovitis is mostly gone by the time we see them. You can barely see any inflammation of the synovial membrane. The cartilage is beautiful. And I think for those who are like, they need rehab and get them back in service. But I think that's rare. And I think Kyla and Wayne, and to probably a lesser extent myself, have had the privilege of operating those horses. For the most part, you go to stick your scalpel in and it's a little crunchy. It's not the one that you're like clunk, or you're taking out a chip based on sales films, right? Those don't, most of those have zero signs of synovitis. Those probably don't need anything post-operatively, but the majority of cases need something afterwards. The one that all the warm bloods, in my opinion, but it's so long by the time they get to you.
Yeah.
Well, it's really interesting, and they're rounded, and they've been there a long time.
They've been there a while.
I say the P1 fragments, but and you're right. Like with thoroughbreds, because most of my practice was racehorses. 90% of them fit the pristine joints status.
Yeah.
And the other 10, it's mild. It's very rare that you feel the need for that. Carpus, it's different. If it's lower joint, middle carpal joint, they need all the help they can get.
Amen.
And whereas, antebrachial carpal joints are so forgiving. It's lovely.
No, I appreciate that. It's great comments. JD, have we got any other pressing questions? I'm conscious of time too. And
We've got a ton of questions. It's going to be really difficult to get to all of them. We've answered quite a few of them with, like, speaking of biologics before or after, at the same time of surgery. We've talked about that. One of the other questions would be duration of effect. which I think we've touched on a little bit, but compared to like in that stifle case, Kyla, would be the steroids and HA were used. What was the duration of effect for that stifle with steroids and HA versus I think you saw it was 6 months with Arthromed. Is that horse still doing well, or have you gone back and retreated it with anything? So maybe if we could speak to duration of effect and potential redosing, because that's come up a bunch.
I guess, and this is again very non-scientifically on duration of effect, but anecdotally speaking to people, to owners and clients reporting back, it seems that it is a longer lasting treatment than some other treatments that I've used. And again, that's like total anecdotal. I don't know if that is going to hold true, but that's the way that it seems to get presented back to me.
Yeah, when I first started using it, I thought, oh, it's permanent, right?
Yeah.
And of course got better at 3 months. It's going to be better forever. Yay, go me.
Yeah.
But then, and that was just too academic. And then what happened was a year later or 18 months later, the horse was lame in the same joint. And now, and we all know, right? You're going to go backwards and you're never going to get back to where you went. So if I have a horse that I know has a known lameness, left front coffin joint, personally, I'm going to inject it with Arthromed every year. And I have several horses that I've injected 3 or 4 years now in the affected joint. They have radiographic changes, they have known degenerative changes, and I just don't want them to go backwards again. And then they're out of commission for however long until they're sound again and back to work.
I know we're out of time, but if I can make a suggestion, we need a whole one of these seminars on dose and what people are using, because, being married to an equine vet who looks at the 9 horses every day and uses quite a bit of Arthromed, but we have a lot of difference in results depending on whether you get a response to treatment. Coffin joints are great, but others are different. And so I think there's a lot of different opinions out there, but I think it'd be really good to talk about it with some dedicated time.
And I would just like to know if Wayne got the Arthromed purple shirt and Kyla and I didn't on purpose.
Oh, I did that. That was innocent, but good point.
Just noticed it.
You know how much time I consider my dress.
Excellent.
Yeah, but it is pretty nice, isn't it?
It is. Not sponsored, I can assure you. So JD, we got a hard stop on time. I'm conscious of our panelists as well.
Yeah, we're over by 2 minutes.
Yeah.
So we probably do have a hard stop at this point. If there's anything
I've got a football game to watch.
Yeah. Is there anything the panelists want to address one last time? I think we're good though. I'm sorry we didn't get to all these questions. We had over 26, 27 questions. We're just not going to get to them all, but I tried to answer as many as we could. We'll try to follow up offline with the rest of them though.
Yeah.
So,
And
We'll have to redo it. We'll have to do another one, like Wayne suggested.
exactly.
No, more than happy. If you guys are keen for that, I'm more than happy. But yeah, people should feel free to reach out to us.
Yeah.
Because this is what it's about. I think we are all learning, and we've definitely got some plans for next year around exactly that, bringing together sort of some symposiums around joint health discussions and bringing the people into the room to have it, because I just think as a new molecule in our therapeutic toolbox, it's just opening up all sorts of possibilities, but there's always stuff to learn, and we'll keep progressing. So really appreciate everyone's time. So I'll hand it to you, to JD, or do we just finish off?
Yeah, thank you guys so much for logging in. If you logged in today, you'll get CE credit. That'll be submitted and sent to you guys shortly within the next week. So we appreciate it. And for our panelists, thank you guys so much. And Jason for moderating the session. That'll do it for tonight. And we'll see you on the next one. Thank you all so much.
Definitely.
Thanks,
Bye.
guys.
Thank you very much, everybody. Thank you.
Bye.